47-year-old female came to us with a complaint of pain in her both knee joint for about 5 years. She has a full range of movement with minimal laxity of the collateral ligaments, and full-length X-ray has revealed reduction of medial joint space and with a varus deformity of 18 degree on right side and 17 degree on the left side. But if we take a X-ray and a weight-bearing X-ray, full-length X-ray and non-weight-bearing full-length X-ray, there is a difference in the angle of deformity in weight-bearing and non-weight-bearing X-rays. Value of increased angle on weight-bearing is called dynamic varus, because this dynamic varus is due to soft tissue and is not a bony deformity. And this dynamic varus is responsible for coronal hypomocleon effect after correction of weight-bearing axis. So once if we correct this deformity and once we shift the weight-bearing axis in the lateral compartment, the dynamic varus will disappear at the tipping point, and to avoid this coronal hypomocleon effect, we should do our all planning in non-weight bearing full length X-ray. Then and then we can achieve the desired correction. Otherwise, we may end up in the overcorrection. If we do planning in a weight bearing, see the difference. There is a lot of difference in planning in weight bearing full length X-ray and non-weight bearing full length X-ray. If we do close wedge according to measurement in weight bearing X-ray, we may end up in the overcorrection. All preoperative planning is done in non-weight bearing X-ray to neutralize dynamic varus. If we do malalignment test, here we can observe that lateral distal femoral angle on right side is 91 and on left side it is 90. Normal mechanical lateral distal femoral angle should be 87. So there is 3 to 4 degree of varus deformity in femur. And if we measure medial proximal tibial angle, that is 80 on both sides. Normal value is 87, so there is a about 7 degree varus deformity in the tibia. So this particular patient has a deformity in both the bones, femur and tibia, but as there is a less than 5 degree deformity in the femur, we may not required to correct the deformity in both the bones to avoid and to reduce the post-operative complication probability. Only proximal high tibial osteotomy was planned, and all the deformity in the distal femur were compensated into the tibia. This is how we did the proximal tibial osteotomy and then shifted the weight-bearing axis at the level of lateral tubercle spine. Here is the post-operative X-rays. We can observe that in a post-operative X-ray here the weight-bearing axis is very well at the lateral tibial spine on both sides, but all planning were done in a non-weight-bearing full-length X-ray. If I could have planned in the weight-bearing X-ray and executed in that way, so it may have ended up in overcorrection. So these are the AP and lateral views of the X-ray, and after this we can see that the varus deformity is corrected well. This is immediate post-op with stitches, and then on the 4th day, as the fixation is very stable, on the 4th day we encourage patient to walk with a walker for the toilet purposes. This is the walking on the 4th post-operative day. Here we can observe that she can walk comfortably, but before allowing full weight bearing on the 4th or 5th post-operative day, surgeons should be confident about the absolutely stable fixation, because if our fixation is not stable, then it can end up in some problems, and there may be some loosening of the internal fixation. So we should have the absolutely stable fixation to allow weight bearing on both sides with a walker on the 4th earlier post-operative phase. Thank you for careful listening. Thank you.